One misconception about the bile duct injury is that, for example, if you had a 2 millimeter clean cut, you will be able to repair it primarily. You may be, but if it's a normal duct, which is already 4 or 5 millimeter in diameter, 2 or 3 millimeter cut is about more than 50%. So there's a very high risk of stenosis. So just because it's a 2 millimeter cut, do not fall for the trap that I would be repairing it primarily. The risk of stricture is much more higher than doing a hepaticoduodenostomy. The other thing about the bile duct is in patients who are undergoing duodenal repair. For example, if you have a patient who had a stab wound to the abdomen with an injury to the second part of the duodenum, or a gunshot wound that damages the anterior wall of the second part of the duodenum, before you repair, make sure you do a cholangiogram. You can do the cholangiogram to the gallbladder or the cystic duct. Make sure you identify your ampulla before you repair, because you would not know where the ampulla is and you may be taking bites of the ampulla while you're repairing injury to the duodenum. So this is very important. The other thing to learn is patients with bleeding duodenal ulcers. Now, they have an erosion into the GDA and they require stitches. The historic teaching is they need stitches at 12 o'clock position, 6 o'clock position, and 3 o'clock position. Now, again, in these patients, you have to make sure you do a cholangiogram and make sure that there's full spillage of this contrast all the way into the duodenum to make sure you have not, in fact, taken a bite of the bile duct. If you have, then this patient may present post-operatively with jaundice and would require a hepaticoduodenostomy there and then.